This is the next case in our Basilar thrombus case series. And this one is interesting because the initial findings were actually on an MRI, but we also have the follow-up CTA neuro-IR procedure and then the final MRI that was done. But we'll start chronologically. So actually this is a patient who initially was noted to have an irregular basilar artery on this time-of-flight imaging on an MRI that was done. And if we can look at the basilar right here, as we go up, we start to notice that it's irregular. Looks like we lose signal right around here. Some reconstitution, but those very, very irregular distal basilar with areas of no signal. And then these, the PCAs, really, the right PCA is not well visualized. That left PCA looks very irregular and small. So overall, this is pretty concerning, especially given that on this initial MRI, there were posterior circulation infarcts, like in the cerebellum here. So this patient ended up getting a CTA for further evaluation, and here we start to see the same pattern where we look at the basilar and we see that it's very irregular, probably goes out there, some distal reconstitution. And really here, once we look on the coronal, we see that as well too, where some areas of non-opacification, this is the basilar, the PCAs do not look well opacified, do not look robust. So this is a good look for a basilar thrombus. And this is not, it's a little different than the prior cases that were shown in this case series. It's probably not as large of a clot, and it looks like it's on a background of some vasculopathy, but there is some occlusive thrombus that is in the distal basilar here and the PCAs, and ultimately on call, when you see this either on the MRI or on the CT, which is the focus of this case series, you want to do a very similar thing where irregular basilar, areas that are not opacifying, this is basilar thrombus, unless proved otherwise, and you want the patient to get a referral to someone who's an endovascular neurosurgeon or neuro-IR so that they can take a look. Now, in this case, we do have the neuro-IR runs. This is from the right vert, and we can see that that distal basilar really is not opacifying well and looks irregular. So there is most certainly some occlusive thrombus that exists, and I'll just show you. This is the left vert run. This, I think, gives us the best picture here too, where that basilar, here's our left vert, comes up, proximal basilar, distal, gets very thready and is partially occluded, and really our PCA opacification is very poor. So unfortunately, there wasn't a good treatment option given the time frame and the underlying vasculopathy for this patient, but going to neuro-IR is definitely the right call to see if there's anything that can be done safely to help help the patient out. And then I'll just show you the final MRI that was done for this patient, just looking at the diffusion. Now we have new infarcts here in the left occipital lobe and the posterior circulation, and there's evolution of that prior cerebellar infarct. And if we look at the ADC, it is dark, corresponding to new acute infarcts kind of in that left occipital lobe. So overall, this is a slightly different look, but the same principles apply. We did not get a non-con CT at this point because we had the findings on the MRI and we wanted just the CTA. But the point is our axials and coronals work really well together, and even though this basilar thrombus looks different, you still want to have a very similar approach on call, which is to escalate to neuro-IR if possible to make sure that the patient has the possibility of timely treatment.